November 6, 2018 meeting. Those minutes were distributed. Are there any corrections or additions to the minutes?
Madam Chair, I'll move those minutes.
I'll second them.
All right, it's been moved and seconded to approve the November 6, 2018 minutes of the Scott County Community Health Board. Any discussion? Hearing none, all in favor, please say aye.
Aye.
Opposed, same sign. Motion carried. Next, we will receive a Community Health Board report from our Community Health Services Administrator, Public Health Staff, and Scott County Medical Director. Good morning.
Good morning, Commissioner Brecky, Commissioners. Thank you for inviting us to present to you today as the Community Health Board meeting, which we are required by statute to meet twice a year as a Community Health Board. Today, we're going to cover a couple of things. We're going to present to you, and we're very pleased to present to you our report to the community. We're also going to have an emergency preparedness update from our emergency preparedness coordinator, Alexa Runquist. Tuberculosis update by our public health supervisor, Noreen Kleinfeld-Weld, and a community health improvement planning update from Dr. Wilcox, who currently is over at the jail, and we're going to hope he makes it on time, but he is expected to be here at 9:30. Our 2018 report to the community highlights the many different ways the community has worked together to improve health in the county. This year's theme of our annual report is really about partnerships and working together to improve health. We recognize that public health can't do it alone, and we really try to utilize a lot of the different partnerships to really expand our reach into the community. We really want to acknowledge the hard work and commitment of all of our partners that really help make some of this work possible. I have provided each of you with a copy of the report, and I'm just going to highlight a few of these partnerships that we had in 2018 throughout the past year and talk just briefly about some of the upcoming work that we have related to these efforts. We continue through a variety of different programs and processes to reduce youth tobacco in the county. Last year, we participated in Kick Butts Day. We received a grant that we were able to provide these schools with some resources to make this possible. And last year, 2 schools participated, and 233 youth participated in this program, and where they pledged to be tobacco-free and signed a big banner. You may have noticed the banner downstairs in the hallway. That was one of the banners that we had last year. This year, we actually just recently finished the program again, and we had 2 middle schools participate, one in Belle Plaine and one in New Prague, and we'll continue this program. We received another grant again. The other work that we've been doing is we've been partnering with Choose Not to Use. We developed some e-cigarette and Juul educational material. E-cigarette use has increasingly become a problem in the schools that we're hearing about. And we partnered with Choose Not to Use, Child and Teen Checkup, and SHIP. And we utilized our in-house expertise of Lori McMillan. And unfortunately, she wasn't able to come today. You may see some of those posters around. Also this year, we were fortunate to have an intern with us who had some skill in this area, and we are currently working on some educational material for parents and youth targeting tobacco, alcohol, marijuana, and opioids. We've also been working hard on improving access in the area of healthy foods. We have the Backstretch Garden over at the CAP agency, and this is a partnership between the county, Canterbury, who is allowing us to use the space, and the CAP agency. Half of those spaces, I believe we have 80 spaces, half of those are dedicated for WIC use, where they teach and enable WIC participants to grow their own vegetables and fresh produce. And we also rent out or lease out the other half of the spaces. So if you're interested in renting a space, please let us know. Excess produce we encourage excess produce to be donated through the CAP. And last year, 800 pounds of produce was donated directly from the garden over to the food shelf. We're also working in partnership with the Resilient Communities Project, the U of M project, to develop plans for edible landscapes or agriscaping. And right now, the students are working on blueprints to really develop from what could be a small scale shrubs in the city to a large food forest in a regional park. We also have a couple cities who've expressed interest in possibly putting edible landscapes in their parks. And we recently received the META grant very recently that will provide some resources if cities or some entities are really looking to do this. We'll be able to provide them with some financial support to make this possible. In the area of early literacy, we've been partnering with the Read Mobile. We work with the library to reach at-risk populations who typically don't engage with the county. And you can see Moise is there. His position is half-time funded through the SHIP program, which we will continue to fund for another year. He has been very successful in identifying up to date 37 friends, families, neighbors care, the daycares that aren't licensed, they don't require to be licensed, but they're with either a friend or a neighbor. And what we're looking at is really engaging them to foster early literacy learning activities within the locations that the kids are. So really increasing their environments to be just more literacy rich. He also has another training coming up with approximately 8 more ones that he has located. So he's been very successful in finding quite a few in a very short period of time. We engage them with different trainings such as infectious diseases, how to reduce transmission in their daycare, as well as CPR training. And this really benefits them, and they really come out for the training and then have been signing up to be part of this network. And we also have been collaborating to improve oral health. During our Marnitas Table event on healthcare, what we heard a lot from the community was lack of access to dental care, or long waits, or they just don't take their insurance. So we've really been working together with system professionals, dental providers, insurance providers, early childhood programs, WIC, to form a dental collaborative to try and increase some of that access. The objective is to really educate children on oral health from the prevention side, even from starting at infancy. What do you do to reduce some of those dental issues? And increasing access. Last year, 2,093 students were screened in 5 elementary schools. This is actually nearly double what we did the year before. So through partnerships and collaboration, we're getting a lot of kids screened. And also, we did a recent screening at Central Family. And of those kids that were screened, 226 of them that were screened, 3 were in the classroom with urgent dental needs that needed to be seen right away, and 22% had visual cavities. So really a high-risk population. In the future, we're going to be partnering with Central Family to provide some dental education to hopefully get on the front end and do some prevention, as well as we are still working with the mobile dental unit in Mankato to hopefully have them come up here and provide mobile dental clinic over by the CAP agency with their vehicle 2 to 3 times a week. And the other area we've been working with partners with is on the area of adverse childhood experiences. We did a training last year that focused on ACEs and building self-healing communities. We had 75 people attend from the community, including teachers, parents, nurses, counselors, etc. And there's been quite a few other ways that we've been working together to improve underlying conditions to make healthy living easier for residents in the county. There are many other stories and data in your annual report. So if you have any questions about the annual report at a later time, once you get a chance to read it, please feel free to send me any questions. And I hope you enjoy it. I'm going to turn it over to Alexa Runquist, and she's going to do the emergency preparedness update. Thank you.
Good morning, Commissioners. Good morning, Chair. Thank you for this opportunity to talk to you about emergency preparedness again. So we're going to start right away with our providers infectious disease class. So back in 2017, I spoke to you about an emergency preparedness class that we taught to childcare. And as a next step to that class, we asked them what they were really interested in, and they said infectious diseases. It was off the charts that they wanted. So I was able to partner, again, using childcare licensing really to find out what they know, and then utilizing the disease control and prevention in our department and build a class around that. So we built a class that focused on awareness, prevention, and control. And we chose these 7 diseases for a variety of reasons.
They are some of the top reportable diseases, and I know that Noreen is going to talk to you a little bit more about reportable diseases during her time up here. And then also I asked our nurses, what do they hear? What do they get calls on? And what do they feel is important? And also this was feedback from what they asked us. So these are chickenpox, fist disease, hand, foot, and mouth, whooping cough, known as pertussis, measles, influenza, and then lice. And ultimately, our main goal, my main goal, was to give them knowledge to make informed choices, because we know that they could always make a better choice if given the knowledge, and so that was our real goal. So we taught 7 classes in 4 different cities. We went to New Prague, Prior Lake, Savage, and Shakopee. We taught 219 providers. So we expanded this year. Licensing said we really think this information would be beneficial to foster care providers, both adult and children. And so we put that out there to them. Our attendees were nurses in schools, faith-based attendees. So we had a great. So we went from 139 to 219 attendees, which is a big one. We taught the class both in Spanish and English. Moises was able to teach those family and friend network that Lisa referred to. He taught a class in Spanish to them and was able to translate all the material, so that was really good. We had a 93% satisfaction rate. We also had a 93% satisfaction rate for all of our instructors. So we had 5 instructors in this class, which was really awesome. Myself, Jamie Carlson, and then Barb Ottinger and Brittany Clay also helped write it. They were our nurses in there, and then Moises, so that was really wonderful. So 219 participants, that was 52% of the providers in Scott County. And when we look at that in terms of how many children does that encompass, those 219 participants would be licensed for about 3,600 kids. So when we look at the reach of that, we think that's a huge reach. And you'll see a little bit later that ultimately it went farther to the families. And so when we use this kind of Minnesota Department's Health household multiplier of those 3,600, we're looking at about an impact of 9,500 people that learn this information. So we're very excited about that. So we gave them a pre-test when they came, just asking them about their knowledge level of the 7 different diseases. And then also, we really wanted them to understand why public health was a part of this. Why are there reportable diseases? What does public health do when there's a reportable disease? And how does that ultimately play into emergency preparedness? So you're seeing the results in yellow of the pre-test and then in blue of the post-test. And you will see that there is a very large gap, almost a 2-point jump in knowledge level of our participants. And so we had almost every participant, I think we had 200 people take the pre and post test. It was optional. So we also, this was their average knowledge level in each of them, and we also tested to see that jumping gap for each individual disease, and we saw that large 2-point jump in each one of those when we taught them. So that was really successful too. We asked them pre-test and post-test if they use the Hennepin County Infectious Disease Child Care Manual. And this is kind of the standard for Minnesota and especially the Metro. It is a wonderful manual that is put together that takes a lot of MDH's material and compiles it into a nice handbook. It is not printed, but it is online. And so 54 were aware of it and using it, and we asked them how many would use it afterwards, and 168 will use this. This provides them the correct information on how to clean, the correct information on how to identify disease. It also provides them fact sheets to give their parents and family members on what to do if they do see that disease, and they can post that information in their child care settings to give their families more information about that. So at the end of them, we asked them, at the end of the evaluation, we asked them, how likely are you to implement a new or additional policy around infectious diseases as a result of the information you learned in this class? And out of 169 responses, 144 of them said they were likely. And so I really wanted to follow up in 3 to 6 months to see if they actually made some changes. And so because our classes were taught over a 6-month period, some of them are still getting their evaluations and turning them in. So the results you're about to see are in the middle of our collection piece. So we sent them a 3 to 6 month evaluation. Oops, going the wrong way. Asking them, do you plan to make changes? And we asked them in this area, have you made changes? In your illness policy, posting the disease fact sheets, because that really can bring awareness to the incident that's happening. Cleaning, have you noticed less illness as a result of the changes you made? Something that child care licensing talked about is often a provider will continue to provide child care when they are sick because they don't have the built-in sick days. And that also spreads disease. And so we talked about the importance of that. And you'll see so that about 30 of the providers added sick days into their contracts as a result of this. And then working with parents and families. What have you changed about that? A lot of them said they just talk to their parents more. When they bring in a child that might be sick, they talk to them about the symptoms to get a better understanding and not just saying, oh, they're not feeling well. What does that look like? So we've seen a very large increase in different policies that were put in there. And we know that these really are a community impact. They're helping to stop the diseases and spreading them farther and farther. So, and we only have, this is only about, I would say, 25% of the participants, but I know that the day I prepared these, I still had them coming in the mail, So I asked the question, who did you tell about this class? Because I really wanted to know, did the information just go home and go into a file, or did you talk about it? And you can see that most of our providers told somebody out there. My personal favorite is the third one, and anyone who would listen. That's kind of what I do in my life. Anybody who's going to listen to me, I'll tell you about it. And you'll see that. But you'll see your facilities families. That was really important. Your spouse, which is often the person that helps them out in the childcare. These are in-home childcare settings, so that's really important. Your personal family members, we saw them talk to other providers. We've had a big reach out for more to offer this class again. We only were able to get to 52%. Everybody has other commitments, so we are looking at offering that again. And again, I just put on the bottom that we know our potential risk is, or our potential reach, was 9,561. But if we look at this chart, we know that it was probably thousands and thousands more. So, yeah, I actually was able to teach this class. A community organization that I'm involved in was aware that I was teaching this class, and so they asked me to come teach it to them. And my son was in there and listened to me give the presentation. And a couple weeks later, my daughter was very sick and she had a rash. And I said to Nolan, what's wrong? And he's like, I think that Audrey has that Fifth's disease. Oh. I said, now why would you know what that is? And I said, I don't think so. And he proceeded to say, well, she's got the red cheeks that won't go away. And, she's kind of been running a fever. And she did not have Fifth's disease. She had strep throat. But it shows you how quickly, right? We didn't think he was probably paying attention during my presentation and just the impact that has and how aware he was of that. So, yeah. The next one, some more community engagement we did, is some follow-up to a survey we did again in 2017 with our House of Worships, and we asked them what they would like to know more about emergency preparedness, and they really wanted a class these are just like childcare providers. They're kind of all over the spectrum on where they are in their emergency preparedness based on the resources that they have. So what you're seeing up on the screen here is our goals for this class. We taught a series of 3 classes, one-time series of 3 classes. We had 6 houses of worship there. They were asked to come with a team. The classes were specifically built in, they had built-in time for them to work in class, because I know that oftentimes emergency preparedness can be pushed to the side, it can be waited on, it's not on the top of our to-do list, and so we purposely built the class with activities in class that they could do as a team and talk about it as a team, and that way the knowledge didn't stay with one person. So each of those 6 houses of worship brought a team varying from 2 to 4 people. So that was exciting. We just did a general understanding about emergency preparedness, what our risks are, what are some of the incidents we've had in Scott County. We brought in the Sheriff's Department. Captain Haas from Emergency Preparedness talked about active shooters in violent incidences. This was the #1 request of our faith-based community, and so he actually spent 2 hours on that one. That was our second class. We talked about planning for and involving at-risk populations. We talked about infectious diseases and how they could become closed pods to help their constituents and the people within their congregation. And then we really spent time in class writing their plans, asking plans, going over example plans. And we did a risk assessment as a whole. Everyone completed it, we compiled it, and then we talked about that and where to go with that. So our next steps with this is they really would like to meet annually. They'd like to tour some of the houses of worship that are farther along in the emergency preparedness classes. And they'd like to just have some one-on-one sessions where they could bring their plans and have us answer questions and things like that. So we're really working with them on their next steps. I had somebody within the first 30 minutes, he was on the board of directors, say, well, this changes everything. And I thought, well, if in the first 30 minutes it changed everything, I did my job. But he said that he had never thought that pastoral care needed to be in the same room as their emergency planning. He didn't understand the impact that a response would have and really the aftermath of an emergency. And we had a couple up there, and so they were great participants, and we know that they have done a lot to change what they're planning for in their house of worship. So another success there. We had 5 out of 5 are likely or very likely to implement new or additional plans or policies. And 5 out of 5 had an increase in knowledge around emergency preparedness. And 5 out of the 5, one of our houses of worship didn't complete the survey, but 5 out of 5 wanted to continue this process and look for ways for collaboration. On April 24th, I was able to conduct a mission critical closed pod point of dispensing. So what that was is, how will we in an anthrax incident take care of our first responders, ensure that they are out there responding to the incident, but their families are protected. So these are actual pictures of our April 24th exercise. We did a full scale. And you will see the library staff actually agreed to staff this for us in a partnership. The director, Jake, said this would be a wonderful opportunity for us and asked for volunteers. And so all these librarians volunteered to come and get trained. They've been getting trained since January, and then they put their training to use. And we were able to, in 2 hours, label 400 bottles of pills. And we actually had, you'll see in the second picture in here, is the chief of police from New Prague participated and came and picked up those medications. So he completed the screening forms with his staff, sent those in to us, and then participated by coming to pick up his medication just like he would in a real incident. So we had the Sheriff's Department participate. We had about 6 other metro organizations come and observe the incident, evaluate for us. We had our hospitals, both of our hospitals from Scott County were participating that day. St. Gert's came over and participated that day because they're a partner with us. It was a great exercise, a great learning opportunity as we really move forward to our next big exercise, which is in 2020. June 17th, 2020, we are being required by our grant to open a full-scale point of dispensing. If we look at what that would serve in a real emergency, it would serve half of our population. So about 75,000, maybe a little under, but we would need to operate a pod that would serve these constituents in 36 hours, so 75,000 people going through this in about 36 hours. So we're gonna test that. Shepherd of the Lake Lutheran Church is our partner and our spot for the day. Prior Lake Police Department will be providing security just as they would in a real event, and so we've already started to begin those planning processes. We have involvement from members of the past All Hazard Committee. We pulled them in and asked them to continue with us in this planning process, and then we'll highly utilize our Medical Reserve Corps, and we hope that all of you guys come out that day, walk through, get your medication, quote-unquote medication, and see what we'll be doing that day. So, yeah. Any questions?
Just a question. In a real event, would you just have one distribution site?
No, we would have 2 distribution sites. Prior Lake High School is our other distribution site. And that is our primary site, but they will be in full construction that day. And so Shepherd of the Lake Lutheran Church would step up. Yep, we'd be operating the 2, and simultaneously our mission critical site would be operating. And that's why it was so important to have the libraries be our partner in that, because we were able to train them and let them focus on that 100%, and we could be focused on the open pods. So, and then we would also have partners that would be operating closed pods, large-scale closed pods.
I was just concerned that 75,000 in 36 hours could not get to one location.
Correct, yes,
I don't think so.
yes, yep. So,
Any other questions? Alexa, thank you. I think that House of Worship training was especially interesting. I know that it was some press in the last days about grants available for houses of worship for security type things. Is any of that covered, or is that something pretty new?
that is not something that I was aware of at the time of our classes. Those classes took in February and March, but we do have a distribution group now and kind of a core group that we could definitely share that information with. Yep, more resources make it much easier,
Yeah,
so,
great. Thank you.
yeah. Well, thank you very much.
All right. Maureen's next.
Good morning, Chairperson Brecky and Commissioners. I'm Noreen Kleinfen-Wald, Public Health Supervisor. I think you know me already. I'll give you a little bit of an update on tuberculosis control and some changing practices that we have had in the field recently. As you're aware, TB control is required by the Local Public Health Act, Statute 145A, and the intent of the statute is to protect the health of the public. We ensure that all of our clients complete adequate treatment for tuberculosis. In the very beginning, these patients may be in isolation because they're infected, and they often feel just really very crummy. But after that initial phase passes, they may have another 4 months, they may have another 8 months of treatment, and so to take your medications on a consistent basis once you're starting to feel good is a very difficult sell. And if they discontinue treatment before their physician recommends, then they can develop a drug-resistant form of TB and become sick again. So this is one of the reasons why we have the statute in place. Another reason is that it is our responsibility to conduct what's called a contact investigation, determine those that have been exposed to TB, always household members, and then taking a look at their work site and making a determination as to who has possibly been exposed to TB. Then we're responsible for getting all of those individuals tested, either with the Mantoux skin test or a newer blood test that is now available. And then those that have been exposed and have been found to be carrying the TB germ in their body, they are given preventative treatment so that they do not develop TB in the upcoming future. Now, TB case management is very labor intensive, especially for a pulmonary case where they have this germ in their lungs. In the beginning, our visits often last 45 minutes to an hour, ensuring that someone is compliant with their isolation, making sure that they understand their health status, their medications, the purpose of the medications, the side effects, and all of these sorts of things. But as I've mentioned, as the cases become stabilized and enter into more of a maintenance mode, the time that we need to spend with the client really shortens down. The federal gold standard of care is to do a daily visit to watch them take their medications, and we call this daily observed therapy, or DOT. And so in 2017, we had 5 patients that had active tuberculosis, and that resulted in about 438 face-to-face visits for our public health nurses. And we were a little bit lucky during this time period. We had one patient that was well enough to return back to her home country and stay there for several months prior to completing treatment. And so we would have had more face-to-face visits had she stayed here for the duration of her treatment. With the advancement of telemedicine in healthcare, it is now permissible for us to do what we call video DOT, where we see these patients via an electronic sort of means. And the Minnesota Department of Health began establishing a protocol for this, and then we developed our own standard operating procedure. Now, our client must meet eligibility criteria, both from a compliance standpoint, that they're very cooperative with us. They need to be at a certain health status, that this would be permissible for us to monitor them more remotely, and then they need to have the technology as well and the capability to do these visits with us via telemedicine. So this was something we put in place in 2017, but at that time we just didn't have any patients that met criteria. Some of the patients, though, that we had in 2018 did meet criteria, and so the gold portion of the bar here is the video DOT visits that we did. So about almost 25% of our visits at that time were done by video DOT. I anticipate that our upcoming statistics will be even better than that. We have a pool of TB patients that are, should I say, more essentially healthy individuals. 2017, a lot of our clients were quite medically frail, and they just didn't meet criteria for doing this video DOT. So I think our statistics for 2019 will be higher. Barb Ottinger is our tuberculosis nurse, and she has calculated the savings that doing video DOT has provided for us. She estimates that in 2018 we saved 46 staff hours. It doesn't sound like a lot of time, but it is more than a week's worth of time for her, and then the mileage reimbursement of about 1,100 miles. And so we estimate that we had a total cost savings of $2,700 by doing video DOT for our clients. Another really good bonus of this practice as well is that our clients really like this. It allows them to be more mobile. We It's less intrusive. We only make one home visit a week to monitor them rather than 5 home visits. Many of these individuals are back at work. They often will leave their employment site at lunchtime, go out to their car, connect with us by video DOT, and we watch them take their medications. So it's far less intrusive and far more convenient as well for our patients. So this is one of our newer practices in TB. So any questions from you?
Commissioner Beer.
Thank you. So the criteria, is it, you mentioned the one pool was medically fragile or frail. Is that specifically because of TB or other health issues, or?
Sometimes other health issues. We've had patients that have had cancer while they've had TB, and they're probably getting TB because they've got some other health issue, and they've been carrying this TB germ in their body for years. Their immune system is now broken down, and so then they get TB. But often we have clients that are medically frail.
And how often is technology the main issue? They don't have a phone, if I'm assuming you just need a phone, or?
That's more unusual.
That they would not?
That they would not have the technology, yes.
Yeah, I mean, this sounds like a great use of technology, and it's new in 17, and 18 was, so at least, yeah, it'd be great to see these numbers. I guess the reason why I was asking that question was, is it a, what I'll call a trust issue versus a technology issue? Like, you need to have someone physically there to see them, to ensure they're taking whatever the medications are, versus just seeing them on a video?
It's really in the very beginning of the case, it's really important for the public health nurse to develop a trusting relationship with this client. And that usually happens quite successfully, because these people oftentimes, they just don't feel good. They're sick, they're in isolation, they're off work, and this sort of thing. But we need to have that time period to establish that a trusting relationship before we can move them on to this telemedicine mode of care.
Fair enough.
Yeah.
Thank you.
Okay. Thank you. Pleasure
Any other
being here
questions?
today.
Thank
Any
you,
other
Noreen.
questions?
Wonderful. Thank you. And Dr. Wilcox is next.
Thank
Good
you.
morning.
Good morning. Well, let me say, folks, again, it's a pleasure for me to have an opportunity to come and be a part of your work this morning. I'd like to chat a little bit about the telemedicine thing, because I can tell you in the area of chronic pain management and chronic medical issue management, we're doing more and more work in the area of using telemedicine hookups now to provide care wherever we find our patients. And you'll be seeing more of that, where we can actually do in-home patient oversight by a telemedicine hookup, and it's going to provide unique opportunities to keep patients at home where they're at, comfortable, and handling their care needs. So we'll see more of that. Now, I have a unique opportunity this morning to expand on the work we're doing in the area of community health and improvement planning. And of course, the work that we do in the area of public health and community health initiatives within our county is extremely important for us who have an interest in this area of patient care. And as a part of that, of course, every year we have benchmarks that we look at achieving relative to how our clients and how our citizens feel their health care is appropriate for them within the county. And as you can see, if you look at data from our state, in 2017, our overall ranking with health outcomes in the eyes of our constituents, and this is data from our public health, we were second. We were felt to be second best in our state in the area of health care and outcome of health care initiatives. This continued to be the case in 2018, and in 2019, unfortunately, there was a bit of a dip in that. Now, we're still doing quite well, I believe. We're fourth out of quite a number of counties in our state to be considered very good with health outcome rankings. but there is a bit of a dip there, and it's always good to know if that has happened, why has that been the case? And if you look at the various parameters then that we build into this health outcome analysis, you can see that where we're taking a bit of a dip is in the clinical care area and also in the physical environment area. We also tend to have a bit of a dip in the quality of life area as well. So bringing all of these factors together, we've had a bit of a dip in 2019 in the perception of our citizens in health outcomes within our county. Now, as we look at that, and we strive to find a reason how we can improve this, we do what we call a community health assessment. We do an assessment on a regular and ongoing basis. It's called a CHA. And as we develop this assessment, we then come up with a plan of care, a plan of health improvement, it's called CHIP, that we might utilize to address these areas of concern of the folks within our county. And that's what you see listed here. It's kind of a wheel and spoke type of approach that we use. We begin an assessment, a community health assessment at the outset. We then determine a community health improvement plan that might be useful in addressing these assessed areas of perceived need. We prioritize those areas. We then go ahead and as a team develop a plan of management in addressing these prioritized issues. We follow through with an implementation, and we then go ahead with data analysis to determine what the outcomes are in the plan that we have attempted to follow. All of this, again, is based upon the community health assessment. And again, it's a plan of improvement that's based upon what our community plan feels is appropriate as we move ahead with these initiatives. So as you can see, what shook out of this assessment then were a grouping of various health-related issues within our county that our folks felt we might look at to assist in improving their perspectives on health care. The number one area of concern was alcohol, tobacco, and drug use. That was the number one area of concern of the folks that completed our survey. And so the goal of all of this would be to increase community knowledge of the issues of youth and adult in areas of alcohol, marijuana, and other drug use, and how we can educate our constituents, families, children, and adults in particular, in how we can manage this and appropriately take care of this and show improvements in this area. What we would hope to achieve then is positively altering youth and adult attitudes and beliefs so that in the long term improvement in this area of patient care would shake out. The second area of concern that shook out of our assessment would be this one: obesity, physical activity, and nutrition related types of problems. Our goal would be to support people in achieving and maintaining a healthy weight. That would be our ultimate goal. And we've already begun work in this area through our SHIP grant. And you've had opportunities to see what we have incorporated into that SHIP grant related to proper diet, proper exercise regimens, and so on. And we're fortunate in that we've recently awarded a grant of about 83 grand to develop some community-driven solutions, again, for healthy eating and active living types of opportunities. A third area and a fourth area of concern that our surveys indicated would be healthcare and mental health access. This, folks, continues to be a major problem. It is not unique to our county. It is a problem we see across our state, across our region, across our nation. The goal from this would be to increase the safety net of services available within our county that would give access to individuals who need access to health care. And we'd look at it from the point of view of developing partnerships through integration of medical, dental, behavioral types of health-related issues. What we'd like to do is expand access and awareness of mental health services in particular, and provide interventional services to folks who need this to support 50% more individuals and families in need of this type of care within our county. Huge problem. mental health-related issues continue to escalate. They're tied in frequently with chemical dependency-related issues through self-medication and so on. And it's a major task for us to continue to strive to address these issues through these pieces of implementation. Another area, adverse childhood experiences. We know for a fact now that individuals who've gone through adverse childhood experiences tend to have significant problems in managing chronic illnesses as they mature. We have scientific evidence and a basis for this now that would indicate adversity during development increases the risk of physical, mental, and behavioral problems throughout our lifetimes. It negatively impacts how we can handle folks who have chronic illnesses of any type. And so our strategies in this area continue to develop. They will target reducing toxic stress in childhood and the promotion of resiliency. Huge area. Any questions at all about how we do our community health assessment? Number one, how we then utilize the information we get from this assessment through our focus groups to determine priority items that we need to move to in addressing the issues that are brought forth.
Questions? Dr. Wilcox, thank you. Just a quick question or I guess a request for your comments.
Sure.
So much of our assessment and so much of what you presented is based on community perceptions. Any comments about perceptions versus the data? Are our perceptions in line with what we're seeing with data in this county?
I would say they are, quite honestly. I think that we've had an excellent opportunity to interact with different social groups, different cultural groups through our focus group work and so on. And the perceptions that we are presented are actual issues that we need to deal with within our county.
Great, thank you.
Sure.
All right. Seeing no further questions, I'd like to thank all the presenters for this informational report. We do not need to take any action on this report. Is there any other business to come before the Community Health Board this morning?
Madam Chair, I'll move that we adjourn the Community Health Board meeting.
Second.
All right, it's been moved and seconded to adjourn the Community Health Board meeting. Any discussion? I will just let everybody know that we will recess for about 3 minutes before starting the county board meeting so that the tapes can be switched, but we'll just remain and we'll convene again as soon as the video room tells us they're ready. So any further discussion? All in favor of adjourning the Community Health Board meeting, please say aye.
Aye.
All opposed, same sign. Motion carried. And the meeting's adjourned.
Tapes, you say?